So I was a resident in internal medicine at McMaster University, and I was very fortunate because Dave Sackett and other senior people in the department, people like Peter Tugwell and Brian Haynes, were already here and had started a new department, the first in the world, of clinical epidemiology. And they were starting to teach people, clinicians, to use the medical literature to optimize their patient care. And they called it critical appraisal at first. And that started as a kind of a classroom activity. And then Dave Sackett came up with the concept of bringing critical appraisal to the bedside, which was to take it right where you're delivering care and using the literature in the very process of delivering care. In 1990, I took over the internal medicine residency program, and my notion was to create the world's first program that would implement this idea of bringing understanding of the evidence to the direct care of the patients. And so evidence-based medicine turned out to be a very catchy name. So with respect to the pharmaceutical industry, what we need to do is to train clinicians and the experts who do, various sorts of experts, who do guidelines for clinicians to be aware of the spin that is put in pharmaceutical industry studies. So the pharmaceutical industry actually does their studies very well, and the data that comes out of it is generally very high quality. The problem is how they interpret the data and how they use it. And that problem is solved by having people who are interpreting the data and interpreting it for clinicians to be able to understand the appropriate interpretation of that data. So that is one issue. In terms of information overload, few clinicians are going to have both the skills and the time to actually critically read the original literature and to use it in their patient care. So what they are going to have to know how to do, understand, and have available is the results of the studies, the benefits and harms, and the magnitude of benefits and harms of, for instance, interventions that they're thinking of using. But they need the summary of the information from somebody else. And so fortunately now we have many institutions providing clinical practice guidelines. We have many systematic reviews, but there is another source of, I think, very good pre-processed information that clinicians can use that ideally will direct them to the best evidence, and then evidence summaries that allows them to understand the benefits and harms that the studies portray. Yes, I think that the grade system has been a big step forward for clinical epidemiology and for evidence-based medicine. And the reason is as follows. It is crucial to be able to distinguish evidence you can trust from evidence that is untrustworthy. And in particular, though, that's probably too strict a dichotomy. There's evidence that you might call high quality, very trustworthy, moderate quality, somewhat less trustworthy, but still pretty trustworthy, low and very low, the very low being very untrustworthy. And if we are going to get it right, we need to know whether our evidence is high, moderate, low, or very low quality. And we need a system that is well developed, carefully thought out, people can apply, has transparent, has rules to allow people to apply the system effectively. And GRADE has done all of that. So starting in the GRADE working group started to meet in 2000, put out its first guidance in 2004, put out many, many papers since then clarifying and deepening the guidance. And it is now a system that's used by over 110 organizations worldwide. It provides a way a uniform, standard, transparent way of deciding what is more trustworthy and what is less trustworthy evidence, which is a big step forward. So what we did was to look at all the evidence bearing on the health effects of red meat. There were 4 systematic reviews that we published, one that focused on observational studies, non-randomized studies, observational studies of people who ate more or less red meat, and the effects on cancer, the effects on cardiovascular disease, and looking at dietary patterns that included more and less red meat, as well as another review that looked at all the randomized trials where people were randomized to diets that had more red meat and less red meat. And the results of this were very clear and actually were quite consistent with prior reviews. So what we found was that the studies do show an association between red meat and cancer and red meat and cardiovascular disease, but the association is a very weak association. And given the biases that are possible in observational studies, because people who eat red meat are different than people who don't eat red meat in ways other than eating their red meat. Moreover, there was one the most convincing large-scale randomized trial available that looked at people who ate more and less red meat, did not show any differences in cancer or cardiovascular disease. So the bottom lines are only low-quality evidence, and even if there is effect, which there may not be, the effect is very small. And the magnitude of gain you would have in cutting your red meat is very small. We then did another systematic review which looked at people's feelings about their meat, what we call their values and preferences. And perhaps not surprising, we found that people who eat meat have lots of reasons for doing it, that they think are good reasons, and that they would not be they might not be at all keen to reduce their red meat consumption substantially for very small and uncertain benefits. So our guideline panel said, okay, so we now want to make a recommendation. And the recommendation is based on this. What do we think that most people, if they understood the evidence and they were red meat eaters, would they choose to reduce or would they not? And what our panel believed is that the majority of people who were informed of the evidence would say, very small effects and uncertain, thanks for the information, but I'll keep eating my meat. And so we made what is a weak recommendation that people continue their current red meat consumption. Why did people get upset at it? People got upset at it because previous recommendations had all been cut down on your red meat. And frankly, if somebody says, wait a minute, let's look at the evidence more carefully to see that that's really legitimate, it's threatening to people who have come out and said everybody should cut down their red meat. The red meat illustrates a problem, which is that people have not been presenting their results as they should to say, this is only low quality evidence, watch out. Subsequent results may show something different. And if people presented it that way, I think that would resolve much of the problem. So at the moment we say, well, red meat might cause cancer and it might cause cardiovascular disease, or it might not. We aren't sure at this point. You should look at the evidence about feasibility, acceptability, and values and preferences, okay? So those 3 concepts are closely linked, but there is evidence about how willing Canadians are to take care of their demented parents and relatives in their homes. And the evidence would show that they're not very willing to do so. And so when you then put a social program into, come up with a social program of how to handle the problem, you would be aware of that evidence and the implications of that evidence on any social program. Being aware that there are issues and handling things about how to deal with your frail, disabled, and demented elderly people, feasibility, acceptability, and values and preferences are crucial. And you need evidence bearing on those issues, and the evidence in bearing on those issues is often crucial in what course of action you should take. The answer is things have changed remarkably little with respect to the physician community, which is split on the matter. And so there are physicians who believe strongly that we should not have financial barriers to access, and indeed that publicly funded systems are not only more equitable, but far more efficient. And there are other doctors who feel that it's legitimate to have people pay for quicker or better care, and so that a system that does that would be preferable. That's all in the background to, I think, again, very little change in what the public thinks, that most Canadians believe that there should not be financial barriers to optimal care, and they put a high value in equity. So if you reimburse physicians for every service they deliver, and they only get reimbursed for one service per visit, you can predict what's going to happen. They're going to get their patients in and out, and they're going to have multiple service visits. However, you can also fund physicians by a capitation-based system in which they get the same amount of money for each person in their practice, no matter how many times they see them in the course of a period of time. That sets up a different set of incentives, and potentially you can take more time with the patient because, again, the reimbursement is not influenced by how much time you take the patient. On the other hand, perhaps your incentive is to see that what we would like to think is that your incentive is to keep patients healthy, right? Because if they're healthy, they don't need to come to see you. You can be out in the golf course earlier on Wednesday afternoons. Unfortunately, it's also an incentive to not see your patients whether they need you or not, okay, right? You get the same amount of money, right? Because the fee-for-service has its limitations and capitation has its limitations. So when we started, we were thinking in a way that turned out to be very unrealistic, that every clinician would have the time and skills to read original papers and the methods and results of those papers. Okay, so one major change has been to shift from, we still think that there are certain things that are worth educating clinicians about looking at papers, and particularly understanding the results. So in my educational practice, I've shifted from assessing risk of bias in studies, which worth still people knowing about, but much more to, can you understand the results? What are the magnitudes of the effects, and what are the certainty, and on what basis do people make their decisions about the certainty of evidence? So that's been one big shift that's happened. The other thing is, at the beginning, if you read what we wrote, values and preferences hardly appeared at all. The right thing to do is different for different people depending on their values and preferences. So there's been a major shift to acknowledge and build into everything we do the issues of people's values and preferences. So as to the future, what we need to do is to build on our understanding that many decisions are value and preference dependent. And the challenge now is to make sure that the choice is correct for every individual. We do that in what has been called shared decision making, which is working with the patient, ensuring they understand what the options are, the evidence behind it, whether it's low or high quality, and what the best guess as to the benefits and downsides are. That turns out to be very challenging. And to do it well, I think we will need what's called point of care decision aids, electronic decision aids, where the physician and the patient are looking at a computer or an iPad or some sort of screen that tells them, okay, here's a summary of the benefits and downsides. First of all, different things are right for people with different personalities. So I never minded being out there, but if you're going to go into that, you'd better think about what you're doing very carefully and have listened to what the alternative points of view are and have your position very well thought out carefully. But once you've done that, I think it's been an extremely positive part of my life to be out there and trying to change, trying to move the world in the direction that I feel it should move. But you have to be ready for people to say not nice things about you. So the extent to you want to be out there saying things that might upset people, you have to think of I don't know if it's ego strength or insensitivity or a thick skin or what it is, but you have to be ready to tolerate that. Well, there's hundreds of ways to get involved. So just to say a few off, the successor of the medical reform group was Canadian Doctors for Medicare, who continues to advocate for universal public funding. And if you do nothing else, you could simply join and find out the information from them and contribute the cause by contributing your membership fee. You could get involved by participating in the boards of community health centers or women's shelters, etc., or all sorts of things like this, and indeed could be one of the physicians delivering care in such institutions.